Narrow Therapeutic Index Drug Monitoring, Principles and Clinical Practice. Drugs with a narrow therapeutic index, NTI, account for approximately 3% of all prescribed medications but are responsible for nearly 25% of adverse drug events requiring hospitalization. These agents exhibit a minimal difference between effective and toxic plasma concentrations, necessitating precise pharmacokinetic monitoring. Therapeutic drug monitoring, TDM, is essential for optimizing efficacy and minimizing toxicity, guided by evidence-based thresholds and clinical context. Management requires individualized dosing, frequent laboratory assessment, and adherence to guideline-recommended monitoring intervals and target ranges. Key points. Note: the therapeutic index, TI, is defined as the ratio of the median toxic dose, TD50, to the median effective dose, ED50. Drugs with a TI less than 2.0 are classified as narrow therapeutic index, NTI, agents. Digoxin has a TI of 1.5, with a target serum concentration of 0.5 to 0.9 nanograms per milliliter in heart failure. Levels greater than or equal to 1.2 nanograms per milliliter are associated with a 30% increased risk of mortality. For warfarin, the target international normalized ratio, INR, is 2.0 to 3.0 for most indications, with an INR greater than 4.0 increasing bleeding risk by 8-fold compared to INR 2.0 to 3.0. Lithium carbonate requires a target serum concentration of 0.6 to 1.0 milliequivalent/L in acute mania, with levels greater than 1.5 milliequivalent/L associated with severe neurotoxicity in 70% of patients. Phenytoin exhibits nonlinear, Michaelis-Menten, pharmacokinetics. A serum concentration greater than 20 micrograms per milliliter increases the risk of ataxia and nystagmus by 45%, and greater than 30 micrograms per milliliter carries a 12% risk of coma. Theophylline has a TI of 1.8, with a target range of 5 to 15 mcg/ml. Levels greater than 20 micrograms per milliliter increase the risk of seizures by 25% and arrhythmias by 18%. Cyclosporin trough levels should be maintained at 100 to 400 nanograms per milliliter in the first 3 months post-kidney transplant, depending on protocol. Levels less than 100 nanograms per milliliter increase acute rejection risk by 35%. Vancomycin trough concentrations should be 10 to 20 mcg/ml for serious gram-positive infections. Troughs less than 10 micrograms per milliliter are associated with a 22% treatment failure rate in MRSA bacteremia. Tacrolimus whole blood trough levels should be 5 to 15 nanograms per milliliter in liver transplant recipients during the first month, with levels less than 5 nanograms per milliliter increasing rejection risk by 40%. Amiodarone, though not routinely monitored by serum levels, has a half-life of 58 days and requires ECG monitoring for QT prolongation greater than 500 milliseconds, which increases torsades de pointes risk by 6-fold. Carbamazepine target serum concentration is 4 to 12 mcg/ml. Levels greater than 15 micrograms per milliliter are associated with diplopia in 50% and ataxia in 30% of patients. Sirolimus trough levels should be. Overview and epidemiology. Narrow therapeutic index, NTI. Drugs are defined as pharmacological agents for which the ratio of the median toxic dose, TD50, to the median effective dose, ED50, is less than 2.0, indicating a minimal margin between therapeutic benefit and toxicity. These medications require careful dosing and therapeutic drug monitoring, TDM, to ensure safety and efficacy. While NTI drugs constitute only about 3% of all prescribed medications, they are implicated in approximately 24.7% of adverse drug events, ADEs, leading to emergency department visits and hospitalizations in the United States, according to the Centers for Disease Control and Prevention, CDC, 2022 surveillance data. The annual economic burden of ADEs related to NTI drugs exceeds $17.7 billion in direct healthcare costs, including hospitalization, laboratory monitoring, and management of complications. Globally, the use of NTI drugs is widespread, with an estimated 15 million patients receiving long-term therapy with agents such as warfarin, digoxin, lithium, or antiepileptics. In the U.S., warfarin alone is prescribed to approximately 2.5 million individuals annually, primarily for atrial fibrillation, prevalence 2.7 to 6.1 million, and venous thromboembolism, VTE, prophylaxis. The incidence of warfarin-related major bleeding is 1.5 to 3.0 events per 100 patient years, with intracranial hemorrhage occurring in 0.2 to 0.5 per 100 patient years. In Europe, the prevalence of bipolar disorder is 0.6%, with lithium prescribed to 30 to 40% of affected patients, translating to over 1.2 million individuals requiring TDM. Antiepileptic drugs, AEDs, such as phenytoin and carbamazepine are used in approximately 3.4 million Americans with epilepsy, prevalence 1.2%. Pathophysiology. The pathophysiological basis of narrow therapeutic index drugs lies in their precise pharmacodynamic targets and nonlinear pharmacokinetics, often involving saturation of metabolic enzymes or transport proteins. These agents typically act on highly specific molecular targets, where minor deviations in concentration can lead to either subtherapeutic effect or cellular toxicity. Digoxin, a cardiac glycoside, inhibits the Na/Kat phosphate pump in myocardial cells, increasing intracellular sodium, which in turn enhances calcium influx via the Na/Ca superscript 2 exchanger. This results in increased contractility, positive inotropy, and reduced conduction through the atrioventricular (AV) node. However, at concentrations greater than 1.2 nanograms per milliliter, digoxin overinhibits Na/Kat phosphate, leading to intracellular calcium overload, delayed afterdepolarizations, and triggered arrhythmias such as ventricular tachycardia or bidirectional VT, genetic variants in the ABCB1 gene, encoding P-glycoprotein, reduce digoxin efflux, increasing serum levels by up to 35% in carriers of the 34-35C greater than T polymorphism. Clinical presentation. The clinical presentation of NTI drug toxicity varies by agent but often includes neurological, cardiovascular, and gastrointestinal manifestations. Classic symptoms are dose and concentration dependent, with early signs frequently overlooked. Digoxin toxicity occurs in 0.5 to 1.0 per 100 patient years. Classic presentation includes nausea, 60%, vomiting, 45%, fatigue, 50%, and visual disturbances such as yellow-green halos, xanthopsia, 30%. Cardiac manifestations include bradyarrhythmias, sinus bradycardia in 40%, AV block in 25%, and tachyarrhythmias, atrial tachycardia with block in 20%, ventricular bigeminy in 15%. Hyperkalemia, K greater than 5.0 milliequivalent/L, is present in 60% of acute overdose cases and correlates with severity. Diagnosis. Diagnosis of NTI drug toxicity relies on a stepwise approach integrating clinical suspicion, laboratory confirmation, and exclusion of mimics. Step 1. Clinical assessment. Obtain a detailed medication history, including dose, duration, recent changes, and concomitant drugs, e.g., amiodarone increases digoxin levels by 70%. Assess for dehydration, renal or hepatic dysfunction, and drug interactions. Key points: digoxin, serum level, reference range 0.5 to 0.9 nanograms per milliliter, therapeutic in HF, 0.5 to 2.0 nanograms per milliliter, acute overdose. Levels greater than 2.0 nanograms per milliliter highly suggestive of toxicity. Check K, normal 3.5 to 5.0 milliequivalent/L, hyperkalemia greater than 5.0 milliequivalent/L in acute overdose indicates severe toxicity. Lithium, serum level, therapeutic 0.6 to 1.0 milliequivalent/L, acute mania, 0.4 to 0.8 milliequivalent/L, maintenance. Toxic, greater than 1.5 milliequivalent/L. Check renal function, BUN, creatinine, TSH, and calcium. Phenytoin, total serum level, therapeutic 10 to 20 mcg/ml. Free fraction increases in hypoalbuminemia. Check LFTs, CBC, and ECG for arrhythmias. Theophylline, serum level, therapeutic 5 to 15 mcg/ml. Toxic greater than 20 micrograms per milliliter. Check ABG, respiratory alkalosis, electrolytes, and ECG. References. 1. Dvorakova et al. Bioavailability of orally administered drugs after bariatric surgery. Current obesity reports. 2024, 13-1141-153. PMID, 381724882, https://pubmed.ncbi.nlm.nih.gov/381724882. DOI 10.1367-S13679-023-00548-7. 2. Lai H. et al. Advances in Surface-Enhanced Raman Spectroscopy for Therapeutic Drug Monitoring. Molecules, Basel, Switzerland. 2024, 30-1. PMID 397950773, https://pubmed.ncbi.nlm.nih.gov/397950773. DOI 10.3390/molecules 300100015. 3. Lemke A. et al. Pharmacogenomics and Beyond. Customized pharmacotherapy for solid organ transplant recipients. Pharmacotherapy. 2023, 43, 7596-608. PMID 369993337, https://pubmed.ncbi.nlm.nih.gov/369993337. DOI 10.1002/FAR2798. 4. Amponsa S.K. et al. Bioanalysis of aminoglycosides using high-performance liquid chromatography. ADMET and DMPK. 2022, 10-127-62. PMID 353606674, https://pubmed.ncbi.nlm.nih.gov/353606674. DOI 10.5599/ADMET.1183. 5. Sheikh M. et al. Advances in Therapeutic Monitoring of Lithium in the Management of Bipolar Disorder. Sensors, Basel, Switzerland. 2022, 22-3. PMID 3516142, https://pubmed.ncbi.nlm.nih.gov/3516142. DOI 10.3390/S220307336. 6. Kosher A. et al. Generic medicinal products in immunosuppressive therapy. Should it be a challenge for therapeutic drug monitoring? Therapeutic drug monitoring. 2023, 45, 2173-190. PMID 369200502, https://pubmed.ncbi.nlm.nih.gov/369200502. DOI 10.1097/FTD.000000000000001041. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.